With that, I will turn it over to Kate.
Thank you, Governor. I also want to thank Secretary Sutters and everyone in your administration for the support and collaboration over the past 2 years during the COVID pandemic. As we emerge from this pandemic, we have a lot of work to do to address the consequences of deferred and specialty care that many people have experienced. But most importantly, and however, there are still significant gaps in our ability to meet the primary care and behavioral health needs of the communities we serve. This legislation and continued focus on the integration of primary care and behavioral health services really goes a long way to meeting those unmet needs. At this point, we know, whether it be firsthand through a loved one or through the news, the pandemic has really exacerbated mental health challenges for both adults and children. There's a particularly acute issue for children. A study by BMC researchers found that rates of depression and anxiety in children of color ages 5 to 11 increased from 5% before the pandemic to 18% during the pandemic. BMC is working to increase access to treatment in a wide range of programs, helping patients in the emergency room connect with behavioral health care, operating an urgent outpatient behavioral health clinic, opening a behavioral health facility in Brockton, increasing our workforce and hiring more community health workers and peer counselors, and integrating behavioral health into our primary care practices. Emergency departments have seen a 24% increase in mental health related visits among children ages 5 to 11 and a 31% increase in children ages 12 to 17. This is according to the CDC. Our clinicians and staff provide amazing care in our emergency department, but that's not the best place to address behavioral health conditions and provide routine care. And that's why we agree with the governor about the importance of primary care and behavioral health care in promoting overall health and preventing acute care needs. At Boston Medical Center, with the support of the Baker administration, we have done many of the things that this bill prioritizes. And so the governor's proposal challenges the healthcare system in many ways. At BMC and at Codman Square and our other CHC colleagues, we're meeting this challenge every day, and here's a few examples in how we're trying to do this. We've integrated, as I said, behavioral health into all of our primary care practices across our hospital. We've embedded an addiction fellow in our emergency department so we can meet people where they are during their recovery. We're using telehealth for some of our ambulatory practices and telepsychiatry for some of our Mass Health Accountable Care Organization patients. We created a joint family medicine psychiatry residency program that combines residencies in family medicine and psychiatry into a curriculum designed to produce dually trained physicians with broad-based experience and expertise in both clinical disciplines. And after 5 years in our program, our residents leave prepared to practice both family medicine and psychiatry in the same practice. People need even more access points to care so they can stay out of the emergency room or the hospital and get the care they need sooner, safer, and closer to home. Investing in additional workforce solutions is also critical, whether it be adding physicians, assistants, social workers, or dental care in clinics, creating new opportunities for people to provide care in different ways, much like our combined family medicine residency program. With more people reporting higher social risks such as food insecurity, housing insecurity, and during the pandemic, it's clear we need to take a holistic view of primary care and mental health treatment, break down barriers, and engage people in new ways. We also know that inadequate rates for behavioral health contribute to lack of access to clinicians, particularly for people who cannot afford to pay out of pocket for care. At Boston Medical Center, we see patients as far away as New Bedford or Lawrence because they cannot find a clinician closer to their home who takes Mass Health. The requirement in the governor's bill that we spend more on behavioral health and primary care will significantly help improve access to those services. The prioritization of the governor's bill around primary care and behavioral health is critical to us to make progress in addressing this crisis. Untreated or undertreated routine behavioral health needs not only prolong suffering of our patients, but they drive medical spend by creating and exacerbating acute care needs, as well as impeding individuals' productivity in the workforce. So I want to thank you for the opportunity to be here today. We look forward to continuing to work with the governor, his team, with Sandra Cotterell and her spectacular team here at Codman Square Health Center, with our other CHC colleagues, with many community organizations dedicated for caring to our patients and the community to bring the policy intent of this legislation to life. And I think it's safe to say that it lives every day here at Cobham Square Health Center, and it's my great honor to introduce my colleague Sandra, who will tell you more about that.
I'd like to thank the governor for coming to Cobham Square Health Center today to talk about something that's been very important for our community. And again, thank Kate and everyone at BMC for really always being there for us and partnering with us. It takes a lot to care for our patients in our community, and we could not do it without your partnership and support. The Cobham Square Health Center was founded in '79, and we have always been a patient-centered medical home approach to our model of care, both offering primary care and specialty services here for all of our families that live in the Dorchester community. But as Kate said, as things have changed in our city, we have patients traveling as far as Randolph, Brockton, and beyond to come here because they've developed a relationship with us and we're able to offer services for them. Before the pandemic, there was always a challenge in terms of access to behavioral health services. And as the governor and Kate described, that issue has magnified. And we're so grateful that the governor understands the crisis and we recognize the importance of your support. Codman offers behavioral health services that are integrated into our primary care services, promoting both overall health and well-being, and we've done that for years, and it's had great success for our community. Our commitment is all-encompassing. Our behavioral health team is comprised of clinicians, family partners, case managers, domestic violence advocates, psychiatrists, and many others. So we have a very robust team that's doing this work. Members of our behavioral health and primary care and other specialty teams work together to offer on-time, in-moment access, as well as assessment and interventions for short-term, as well as traditional therapy services and referrals for higher levels of care in the community. Additionally, like Boston Medical Center, we also, during the pandemic, was able to stand up telehealth as well as telepsychiatry and offer services not only for behavioral health but primary care and other specialties so that our patients could continue to get access. Our specialty care teams include medication-assisted treatment for substance abuse, chronic disease management, and care for people living with HIV. We need to continue to build on our collaborations and our partnerships that exist. Two partnerships that I'd like to highlight. One is our Team Up initiative with Boston Medical Center and 6 other health centers that transform and strengthens behavioral health care for children. We also offer behavioral health services at our school-based center at Tech Boston, meeting kids where they're at to provide access to behavioral health services and other services that they need. We are a training site for the next generation of healthcare professionals that are learning to integrate behavioral health into the primary care practice. We're training sites for residents, medical students from area hospitals, including Boston Medical Center, but also behavioral health clinicians who are coming to us from area colleges and universities. We are all aware of shortages of providers, and we are encouraged that this bill will help alleviate some of those shortages in the long term. You're right now in the Black Box Theater at the Cobham Square Health Center that is a resident of both the health center and the school, and we're digging deep into our youth at the school to give them access and expose them to careers in health while they're in high school. And we're offering internship opportunities for students during the school year as well as in the summer. So there is, as the governor and Kate said, a lot to be done, but we're committed to doing what it's going to take to keep the city of Boston and our patients in this community healthy. And we're looking forward to partnering with everyone in this effort. We also cannot thank the governor, Secretary Sutters and her team, Kate and the BMC team for their continued support, and look forward to working on this journey with them. So thank you, and I'd like to turn it back over to the governor.
Thanks, Sandra. Questions?
Governor, how confident are you with just a few months left in the session that lawmakers will actually take this up and do something?
So I guess I'd say a couple things about that. The first is several of the elements that were part of this bill when we filed it in 2019 ended up becoming emergency orders, and then after becoming emergency orders during the pandemic were part of the legislation that we signed at the end of the session last time. And I think in many ways, part of the reason why those particular initiatives like telehealth, which we'd been to the well on more than once, got enacted was people had a chance to see that in real life and in day-to-day terms, especially during the pandemic, that turned out to be an enormously effective way to keep people, especially dealing with addiction issues, behavioral health issues, geriatric issues, primary care issues, close to their clinicians when people really didn't want to go to the office for a visit. It also kept them out of the hospital, and I think that was particularly important at that point in time as well. So I believe many of these items have what I would describe as a demonstrated degree of success. No one disputes the fact that at this point we have very significant issues with respect to behavioral health access. I mean, honestly, I don't think I've found anybody in Massachusetts who thinks we have enough people playing in the behavioral health space to take care of the people who are trying to access services. And as Kate's statistics pointed out, there's been a significant increase in people struggling with mental health issues, primarily as a result of the pandemic. But we had issues here with respect to access to those services before the pandemic, which is why we filed the legislation in the first place back in 2019 to increase access and to provide more funding and support for those kinds of services. I think this is one that the legislature is well aware is a problem. I think it's an issue that the legislature understands the importance of doing something about. And we've had conversations with them all along about the stuff that was in that bill we filed back in 19, how much of it ended up in executive orders, and how some of it got dealt with as part of that legislation that we signed a little while ago. I have no doubt this will get a pretty solid and significant hearing during this session, and I would love to see it get signed.
Yesterday, we saw your tax cut package. It really didn't seem, when you take away from that event, it didn't seem as though there was a sense of urgency to act on that, for instance. So you think this is different?
Oh, I'm expecting that we'll probably see something happen on both tax cuts and on something like this between now and the end of the session. I mean, look, stuff happens, right? We all know that. But one way you can measure whether or not, in fact, there's interest in something is, are you pursuing something that folks in the legislature are talking about and engaging with you on? And on both this issue around mental health services and behavioral health care and on tax cuts, very different issues, there's a lot of back and forth, which is a good sign.
Governor, can you talk about emergency room boarding and how
Yeah.
you think the regulation would affect that? And maybe create an online portal that's similar to the Mental Health Agency Act, or how you're so different?
I do think the behavioral health roadmap, which we're hoping the legislature will enact as part of the fiscal 23 budget, will create a single front door for people who are accessing or need to access behavioral health services, which I think will make a big difference. However, that difference, in my mind, needs to come with a commitment to additional financial support for what I think we would all agree is an under-resourced behavioral health and primary care community to begin with. That's what this legislation is all about. We've put very significant resources into what I would call the state-funded behavioral health and mental health system over the past 5 or 6 years. I mean, I'm talking, I bet it's $600 or $700 million in new money at this point, not counting some of the stuff that Mass Health has done. Those dollars have made a difference, but that's just the state piece. This bill is talking about a systemic-wide investment over the course of 3 years in behavioral health and primary care that would probably be worth somewhere between $1 billion and $1.5 billion in incremental spending on these activities. And the reason I say it's so important that we spend additional funding on these activities is if you don't spend the money, you're not going to get the participation. Okay, now I'm going to nerd out here for a minute, and I apologize for this, but we do not have a single payer in the United States, but what we do have is a single platform on which reimbursement across almost every provider and every payer is based, and that's called Medicare. And Medicare, generally speaking, has always favored technology and transactional services over what we would call soft services. Soft services being primary care, addiction treatment, behavioral health services, geriatrics. And that's why when you look at the average salaries that are earned by people in pediatrics or people in primary care or people in geriatrics or people in addiction medicine or people in mental health services, in many cases, they're half or less of what a lot of folks in the high-end surgical specialties earn. So if you're going to medical school and you're going to walk out of that medical school with the same debt, whether you go into surgery or you go into geriatrics, where are a lot of people going to go? They're going to go into surgery. And that's why the United States and Massachusetts has a completely different ratio of providers who are available to serve patients than other countries. I mean, in most countries, the relationship between the primary care, mental health, geriatric, addiction specialists, and everybody else is about 50-50 to all the rest of the high-end specialties, because they finance the system that way. That's how they choose to pay for services. We don't do that. We're more like 75-25 high-end specialists and everybody else, 70-30, somewhere in there. And if you look at the folks coming out of medical school now, it's more like 85-15. If you want to have a robust primary care, behavioral health, geriatric service available at a point in time when everybody agrees we have enormous issues with care coordination, behavioral health, addiction, and seniors, you have to be willing to fund it. And the way we would fund it here in Massachusetts is by using our existing health policy commission and the structure that's already in place to deviate from that national fee schedule that drives business everywhere else, and to require, not encourage, and require providers and payers to put more resources into primary care and behavioral health services. It's the only way I know of to put enough resources into the system so that people do get served in the community. They do get access to regular treatment, so they don't end up in your ER, where we then have enormous challenges with respect to getting them from that ER into an acute level of care that specializes in mental health. The other thing I think that would happen if we headed down this road, it wouldn't happen right away, but you would see more providers interested in putting beds up that would be available to serve people who are looking for those kinds of services and need those kinds of services. But what we really ought to be doing here is a much better job and a much more robust job of serving people in the community. But to do that, you have to put the resources in to build that capacity, which we currently do not, and nor do most other states in the U.S.
And how do we make sure that the providers are also in Western Massachusetts, is just thinking about more rural communities where there's not as big of populations, to make sure that they're not only dependent on, say, telehealth compared to people in Boston who have more access?
I think part of I think the point here is if you put more money into certain kinds of services, you will get more of them. I mean, that's kind of the way markets work. And in this particular case, we have underinvested in primary care, geriatrics, and mental health services, and as a result, we have a lot less than what we need, especially coming out of the pandemic. I do know that in Western Mass, people found the telehealth service, which we've been arguing for several years and put in through that emergency order, to be an enormously beneficial service for them. And I do think over time, people are going to discover they can use telehealth for a wide range of services. And I will say this, especially about mental health services and addiction services, the dropout rates, and again, I would want these two to speak to this, but the dropout rates for telehealth services in mental health and behavioral health are infinitesimal compared to what they were when people had to travel. And in rural parts of Massachusetts, like Western Mass, the travel issue is a much bigger deal. The other thing that happens is you can access through telehealth, let's suppose you have a child who's dealing with an eating disorder, and there are only a couple of providers in your general vicinity who deal with this, and their panels for the most part are full. You can access a specialist who deals with these issues anywhere in Massachusetts under telehealth, which makes it much easier for folks to find providers who have specialized skill sets that they're looking for to serve either themselves or their families. But you guys should really, you in particular, Kate, should speak to that question.
I would just point to what's called the no-show rate in our behavioral health practices at BMC. Before the pandemic, in our site clinics, the no-show rate was, on a good day, 30%. That means, 30% of the patients who were booked didn't show up. During the pandemic, when we were seeing patients versus in telehealth, we were at 100%, 110% capacity. So people were able to see their providers. Now, if the chair of psychiatry were standing next to me, he'd say, it's not a panacea, it's a Band-Aid, but it's a Band-Aid we can stretch over a wound till we can get that person into care. And there's a difference between phone health and telehealth. Doctors need to be able to see their patients, which is why the expansion of telehealth services and making those available to people who may live in digital deserts or may not have access to data plans is a really important part of the work that we do at BMC and here at Codman. It's not just enough to have telehealth, it has to work. The other thing I would say is to set up for a telehealth visit so it's productive, the staff need to do a lot of work, and maybe Sandra, because she's a nurse, can tell you more about what that is.
I think you're right. We saw, you saw 30% no-show rate. Our no-show rate in our behavioral health was as high as 50% at times. And so with telehealth, we were able to see 100% show rate. And it is a lot of setup. I mean, the same work that you have to do to schedule, to follow up with the patient, setting up the room, setting up if it is the video, setting that up so the clinician is ready to start that session, but also the follow-up that has to happen, because now after the clinician's done, there's still all the follow-up with that comprehensive team, and that all has to still be coordinated. So there's a lot of work behind it, but very well utilized, and it's worth the investment because you're now meeting people where before, when they had to get in here, we weren't seeing that. So it's really had a tremendous advantage in terms of access.
Other questions? Well, thanks very much for coming, folks. And again, to Sandra and Kate, thank you not just for hosting us, but for all the work you do. And let's hope we can get this legislation done so we can build some additional capacity in mental health and primary care, because we could sure use it here in Massachusetts. Thank you.
Thank you.